Dr. Payne, as you know, is here. Ready to talk.
What are we talking about today, big guy?
I don't know. You're paying for it.
Come on. You should know enough stuff by now. What do you want to talk about?
Well, with me, it always centers around the lower back. You know me.
Low back?
I
think we should go with knees and shoulders today.
Head, shoulders, knees, and toes.
We did low back for the last few weeks. And then next week, we will have Dr. Amendolia, who's the spinal stenosis expert. So if you know somebody who has spinal stenosis or you have spinal stenosis, you absolutely need to listen in next week because... we could do a show for like 100%. 8 hours with him and you wouldn't run out of information. So incredibly important stuff, especially for people dealing with that, because as you know, stenosis is not something that's going away. I had a patient this week with I have many patients every week with stenosis, but specifically a person who didn't even know what it was. And, once I sat there and explained everything to him, he was like, so there's no cure for this? It's like, no, this is what it is. Like, this is what you have. This is what you're going to have to deal with.
There's management.
And there's management. Yeah, absolutely. Mm-hmm. There's absolutely management. But, again, there's this misconception when it comes to pain management that there's cures, right? Like that if you've hurt your knee or you've hurt your low back or whatever, that there must be a cure and then, you're never going to feel this again. That's not what the reality is. The reality is the exact opposite. Once you sustain something once, you are more likely to sustain that exact same injury. And every time that happens, it only gets worse. The frequency becomes more. The duration of the pain becomes more. So it's not good news. I'm not saying anything good here. So get these things dealt with, early on. Don't wait for them to become chronic issues that, have happened several times. You've never had it looked at. Like, how many people have we had called the show that they have this history? It's like, well, what have you done for it? Nothing. It's like,
did a couple weeks of physio.
If even that, I would say that's something. How many people are self-diagnosing, right? Yeah. They're saying, well, I know what it is, and so I've gone and done, my own little therapy or whatever. It's like, that's not the way it works. Step one, if you have a question and your question is what should you do and you haven't seen anybody, step one is you need to see a professional and get it figured out. And someone who knows what they're doing, right? Because not everybody knows what they're doing. I actually had a voicemail this morning where the person asked me if I would understand more than the general family doctor about these musculoskeletal pain injuries. And I would like to say that the answer is yes. Now, I don't know every single family doctor. Someone might be incredibly well-versed, but this is my bread and butter. This is what I deal with. I deal with pain management, musculoskeletal issues, so I think I understand them to a very high degree. I also work very closely with a sports medicine physician who's also an orthopedic surgeon, and we work on a lot of complex cases together, because a lot of these things are very complex and trying to figure out the root cause and what the best treatment is. So, and that's just one person that I essentially work side by side with, but my team is very, very big, all different types of healthcare professionals, and we will do what are called rounds around difficult patients. Like, how do you collaborate in terms of having more than one opinion from more than one profession? Because that's very, very important.
Well, it's the knowledge that week in, week out you put out there. I mean, you mentioned it right there in that voicemail. This person you talked to had never heard of stenosis, and I know we had a pre-chat coming up on the show next week with Dr. Amendolia that the aging population in Japan, I remember him mentioning, I know he'll talk about it on the show, where 60% of the population, because they're living so long, stenosis is running rampant over there, and people they got to get their learn on about it, right?
Well, yeah, because stenosis is one of those things that it's degenerative, right? And so stenosis is that narrowing of the canal where the nerves come out, and you can either have congenital issues. So sometimes people are just born with a vertebrae that's smaller, has shorter pedicles, and that will create a smaller space, and that's what we would call congenital. It's from birth. It is what it is. But most of the time, the stenosis is degenerative in nature, so that, as the bone starts to wear out and it starts to get bigger and uglier and it starts to impinge on that hole, then that's what becomes spinal stenosis. So naturally, I tell everybody when they come in and say that they have arthritis or degeneration, and when we're talking about the regular type of arthritis, which is wear and tear, of course you're gonna have more when you're older than when you're younger. Like you will likely have a little bit more than me. Someone who's older than you will likely have a little bit more than you. What we're really looking for a lot of the times is does someone at a certain age have more than what we would expect in that age range? But yeah, absolutely. As the population of a country gets older, more and more people are absolutely going to experience stenosis, unfortunately. And so, yeah, next week's going to be an incredibly informative week for a lot of people to listen to that and what are the right things that can be done.
But this weekend is just underway. David, thanks for calling in already. How are you?
Oh, not too bad.
What's going on?
Just wanted to ask a question. I have several deteriorated discs in my neck, and I was talking to a pain management specialist about something he called radio frequency ablation.
Yep.
I just needed some clarification on that before I commit myself to that kind of procedure. Is it just a removal of the nerves, or?
Well, ablation is when it's a process that's used medically, and it can be used for a lot of different things, but it's essentially when you use heat to get rid of a tissue. So they can sometimes do it with tumors, for example. They can do it with discs. So it's essentially using heat to ablate whatever they want to get out.
Yeah, he was talking about the pain management, just zapping the nerves. Is that something that will grow back, or?
Well, nerve tissue doesn't. No. So, I mean, one of the big things about nerve tissue, why nerve issues are so hard for us to deal with, is that most of your cells in your body regenerate, right? So if you get a cut, that's a rupture in the skin cells, but all of a sudden, a few weeks later, your skin is back intact, right? Nerve tissue doesn't regenerate well, which is the problem with people that are paralyzed, that we don't have a good answer to regenerating the nerves. Now, so no, it likely will not regenerate. Now, nothing is impossible, but, it really comes down to, usually when they're trying to do that, it's to essentially destroy the whole pathway of that nerve. Now, remember, pain is not the only thing that travels in a nerve. So is sensation, so is all the other sensory information that we require. So it really depends. I don't know enough about what's going on with you to understand if it's the right thing for you to be doing.
Well, it's been a problem with pain management for almost a decade now.
Mm-hmm.
I work with the armed forces, and so a lot of heavy loads, a lot of long days type of thing. Now here I am.
Right.
But do you consider this a risky procedure?
Again, that's a tough thing for me to say. Just cold turkey on the air, saying is it risky? It depends. Like, what other things have you done over the last decade for your neck pain?
Mostly just massage therapy, acupuncture, pain pills.
Yeah,
a lot of those.
So John will know what's he missing right off the bat. Like, what has he not done? He's
physical intervention.
Yeah, like have you done rehabilitation of your neck, like true proper exercises, guided exercises that you do over time?
There's a sports medicine place at Shepherd and Young I go to, or did go to. I did about 30 sessions.
Yeah.
With the neck exercises.
Yeah, but and that's so. Just saying that you did so proper rehabilitation means that there are exercises that you're doing every single day. So just think about what you said: 30 sessions. So that's the equivalent of a month if you did it every day, and you've been dealing with neck pain for 10 years. The exercise when you need to do the proper exercise, it's something that you don't ever stop doing. That's how you manage the issues. Now, I'm a big believer that things should be managed least invasively first. Now, there are people who do all of the appropriate exercise, all of the appropriate rehabilitation, and don't get better. That's when I would consider moving towards more invasive procedures. Now, if you're sitting there telling me that you haven't done some of the very, very key things, the research on spine-related pain, chronic spine-related pain, is pretty good in terms of determining that the best option that we have is the right exercises that the person does for the rest of their lives, and they have to be the right exercise. So you're missing one very, very important thing. If arguably the most important thing, and you're already jumping to maybe, getting nerves burnt. I don't know. Again, I don't know enough about your case to comment whether you should or should not, but just based on the sounds of it, I think it's always worthwhile to try the least invasive procedures first and try to get the maximal benefit out of those.
Yeah, I do yoga, but
that's not the proper rehabilitation, though.
No.
Yeah, true enough.
It's good. I mean, that's part of it, but it's totally different what you should be doing.
Dave, appreciate the call. Follow up 1-855-55 Lou, DRLOU, or info@paincarecanada.com. Use one or both of those and get in touch. Lots more of the Dr. Payne Show is on the way. Just getting rolling. You want to call? Would love to talk to you as well. If you have some issues, want to discuss, 416-870-6400, star 640 on your cell. Dr. Payne Show, Global News Radio 640, Toronto. Open lines, plenty of room for you at 1118 416-870-6400, star 640 on cell. We like to talk about what ails you. Marcy, good morning.
Hi. So around 3-4 years ago, I started experiencing really a lot of low back pain. I was diagnosed with osteoarthritis.
Yep.
Started working with a physiotherapist, chiropractor, doing regular, really core strengthening. I realized that I was a runner, and I realized that I wasn't doing a lot for core other than planking.
Yep.
Then I started getting nerve pain down my right leg. I've been having on and off again sciatica on my right side. My first MRI showed nothing. Second MRI 2 years ago showed bulging discs and some small stenosis. Now I have sciatica on both sides, still have low back pain, and my most recent MRI last month shows severe spinal stenosis bilateral and severe bilateral facet joint degeneration.
When was the last MRI before that one?
Was November 2017, and then I had one October 2018. And year over year, there was a big degeneration.
Yeah, okay, so that needs to be investigated. Do you have any type of autoimmune diseases?
Not that I'm aware of.
Okay.
Like otherwise, I'm a completely healthy person, but my back just keeps on getting worse and worse.
And how old are you?
I'm 55.
Yeah, I mean that's a big jump, right? Like if I saw an MRI from 10 years later and it was progressed that way, that sort of makes sense. But in a year's time, for it to go from very little to severe arthritis, are you osteoporotic at all?
I don't think so. No, not really. So 3 years ago showed really nothing. 2 years ago showed moderate. A year ago, like this time, showed moderate, and now it's saying severe.
Severe. Yeah. Well, that's a quick progression in 3 years. Okay.
So I've been referred to orthopedic surgeon at Sunnybrook.
Yeah.
I've been doing spinal decompression right now with the chiropractor. It really has helped with the pain. It hasn't made it go away completely, but I could now stand and walk for longer than 5 minutes at a time before my leg goes entirely numb. But it's also extremely expensive.
Yeah. So
I've gone through all my insurance, obviously.
Yeah. So again, next week, Dr. Amendolia will be here. He actually has a spinal boot camp down at Mount Sinai where his clinic is. And I mean, the therapy for spinal stenosis is very much related to the things you should be doing. And decompression is not on the list of those things. And so it needs to be, and it's too much for us to go into on the air here in terms of what exactly should be done. But there are better options. And his work is scientifically tested, right? So, and people do get benefits. And again, the unfortunate reality is this about spinal stenosis. Now, you're being referred to an orthopedic surgeon. Is the spinal stenosis specifically only at one level? Like, is it just like L3, L4? Like, do you remember what they said, or is it throughout your whole spine?
No, not my whole spine. It's L5, S1.
On one side or both sides?
Bilateral.
Okay. Well, that's better from a surgical perspective, right? Because they know exactly where they can go in and do it. A lot of times you'll see people that have severe spinal stenosis throughout, and that's quite difficult because where do you start and where do you stop? But that's likely why you're being referred there. Now, spine surgery is no joke, and just as a stat, 98% of people that are referred to a spine surgeon don't need surgery. So don't be surprised if the surgeon doesn't want to operate. So that's something to keep in mind. But I think an exercise-based spinal stenosis program is a much better option for you. And I think you should give me a call and come in for an assessment, and we can go through that.
Okay, appreciate it. Thank you.
No problem.
Bye-bye.
Thank you, Marcy. Appreciate your call. Enjoy the rest of your weekend. 1-855-55 Dr. Lou, DRLOU, info@paincarecanada.com. And for the remainder of this show here on the air, you want to chat, ask a question just like Marcy did, do so. 416-870 6400 star 640 on sale. Dr. Payne Show, Global News Radio, 640 Toronto. 416-870-6400 star 640 on sale.
And I'll be here for the rest of the hour. I didn't win the
You just
the
checked
lotto.
your Lotto Max, eh?
Yeah, I didn't win, so we're
I
staying.
heard some dee-dee-dee-dee-dee-dee. What was
One
that?
free play.
Ooh, my cup runneth over.
Yeah, I got a chance next week.
Got a chance.
You all know when I win, when I'm not back.
Calvin,
Yes.
the money guy,
Yeah.
texts me.
Yes.
And I assume he's serious here, so I'm going to ask you this. Hey, I'm listening to Dr. Payne. I was going to wait for him. Can you ask him if both your wrists are sore and knees are painful when I get up, what do I do?
So loaded. So, I mean,
Both wrists, both knees.
when he wakes up in the morning.
Yeah, when he gets up, what do I do? Thanks, Calvin.
Yeah. So, I mean, number one, again, when you're dealing with something like that, so I'd want to know some things like, does he have swelling as well, or is it just simply pain? The nature of his work. He's a money guy, so he's probably at a desk a lot. The risk could just simply be a mechanical thing. I don't know the other history about his activity. Like,
Here's an idea, Calvin. You do a radio show. You know how this works.
Try to call in.
416-870-6400.
Yeah, I'd like to know a little bit more for sure. I mean, one of the things when you hear multiple joint involvement and bilaterally on both sides, you cannot exclude without at least some questioning and stuff. Could there be something here that's, systemic in the blood, like an autoimmune disease or something like that? Now, I don't know him. I've listened to him before. You know him better than me. Does he otherwise look healthy? Like, yeah.
Average looking dude.
Yeah. So, yeah, I mean, that's one thing to consider. Or it's just simply mechanical. Could be related to the way he's sleeping. Knees, that one's a little trickier. Like, the wrist definitely can be affected with sleep postures and things like that. The knee might be related to activities or shoes or things that he's wearing. So there's a lot, but I think you're right. He needs to call in order for me to have a better idea.
Knees are a wacky joint.
They're a wacky joint.
They're above and below a stable joint, right? So they're kind of flying in the wind, right?
They're a stable joint above and below two more unstable joints.
Really?
Yeah. So the hip has more degree of freedom than the knee does. The knee is very similar to the elbow, right? It's a simple hinge joint, one unidirectional, like it's either going to flex or it's going to extend, and that's really the extent of it. And so it's a simpler joint,
okay.
But a lot of things happen to it because of it being in between the two other joints that I mentioned, which is the ankle and the hip. That degree of mobility on either end of it means that knee being unidirectional is going to take a lot of abuse because you've got two mobile joints above and below. So, there's a lot of things that can happen in the knee. I mean, the biggest things to consider with knee pain is, number one, is it some type of ligament or meniscus issue?
Okay.
And then if it's not that, is it something like the osteoarthritis, which in the knee can become very significant? And the other thing is it just simply a functional issue? There's a lot of muscles in that area, right? And a lot of it has to simply due to a functional issue. So things like patellofemoral pain, which is just a tracking issue of the kneecap that creates pain. So there's a lot of things that can go wrong in the knee. Again, we haven't talked about this in a while. Our initiative with the knee clinic is very, very important. It's essentially designed that if you need surgery, waiting, okay, is not going to help you. So I'll give you an example. I had a patient, and we're even doing this for some other areas of the body. So anything that you have an injury in that you think might be a surgical thing when we're dealing with the upper extremity or the lower extremity, you need to call me. We had a patient that called, was moving something, heard a pop in his bicep. So right off the bat, we got him in. We looked at it. We could already see it was
torn.
It was torn, yeah. Sent him for an MRI, had the MRI the next day, had surgery a few days later. That's all within a week. And the reason why that's done is because the longer you leave that, the more problems you create. And if you go the more traditional route of, walk-in clinic or family doctor referral, these things can be long drawn out. And if that's the case, all you're doing is hindering your prognosis. So if you have something that's potentially that serious, you need to call me right away, because the sooner you get that looked at, the better your outcome is.
When you say pop, it makes me cringe. A popping noise in your bicep. Did it
loud.
Curl right up? Was it detached or not?
Yeah. I mean, so people that have snapped their Achilles tendons, which is at the back of your ankle, when that snaps, it sounds like a shotgun. That's how loud it is.
Oh, stop it.
That's how loud it is. Yeah.
Seriously.
Yeah.
Stupid question before we go. Is there a lot of pain involved, or the noise is worse than the pain?
It's a good question. A lot of times when you tear something completely, you also sever the nerve in terms of pain. So sometimes no, but sometimes, I mean, you should try it. That's the only thing
I'm good. I'm all right. 416-870-6400, star 640 on cell. Give us a call. Let's chat right till 12. Dr. Payne Show, Global News Radio 640 Toronto. 11:32, Dr. Payne Show. 416-870-6400, star 640 on cell. You know, we just, moments before we went back on air, we were talking about biceps. And every guy in the world has done it at least once. No, not that. I'm talking about bicep curls in the gym.
That was the perfect time for that noise too, eh?
And you said...
What do you guys call that in radio when the timing's perfect? What's
good
that?
timing. I don't know. What do you call it?
No, when you like set something up with the song, you're all
hitting the post.
Hitting the post.
Yeah. Yes. See? You don't even know. It's a radio guy.
Anyway, bicep curls, doing them straight or supinating the wrist. That's the actual...
Well, supination is the whole motion, right? So if you're holding your palm upwards, that's supination. So that whole process is supination, right? So it's not just any static point, but obviously you are in full supination when you've done this, right? Because you could do the hammer curls too, where you're essentially...
Up and down.
Yeah.
Right? But that's more of a forearm thing.
Yeah, you're going to get more of the brachioradialis, right? But versus doing it in full supination, that's where you really start to activate the bicep.
So like an easy curl bar on a preacher would be that type of movement,
Yeah,
right?
the easy curl also keeps you more slightly... not full supination. Like the straight bar, like a straight barbell is going to give you full supination, or even like a dumbbell on a preacher curl bench is gonna be a really, really good exercise.
So what's better to target the bicep? An easy curl or flat barbell? For rehab or otherwise.
Yeah, rehab is different, I guess, for just in general. You know, it also depends on the person's morphology. Like, not some people, you have to also look at the way their shoulder is, because the bicep attaches up into the coracoid process of the shoulder. So it very much depends on the person's body type. But the more supinated, the more of the activation of the bicep you'll get.
So true, because some guys like myself, no luck with doing biceps.
And you might just be doing it wrong for your body type.
Probably.
I would just stop it.
Just go home and go to have a wee lie down. Diane, good morning. How are you?
I'm good, thank you.
Good. What's going on with you?
I have what I believe might be a tear, not in the shoulder, not in the joint, but it's fully mobile. But when I go to put a jacket on or put my seatbelt in the car, and the pain is excruciating.
Okay. So what makes you think it's a tear?
The fact that there's no pain in the joint.
Yeah, that's not. No, that wouldn't be. So what happened? So how long has this been going on?
It's been going on about 8 months.
Okay.
And I don't actually know how I do it. I have a pretty physical job.
Yeah.
But I don't know anything that I would have done to have done this.
Have you had it checked out at all by anybody?
No, I'm pretty stubborn.
Yeah. So that's step one, right? We started the show by talking about that you got to for you to assume that it could or could not be something. You're likely going to be wrong, in all honesty. So I think the best thing is to get that checked out, whether it's by me or someone else that knows what they're doing. But you need to get it looked at, and oftentimes it's not tears, which is good. And a lot of shoulders have tears in the tendons already, anyways, because it's kind of a degenerative process. But yeah, you got to get it figured out if it's been going on. Now you're at 8 months, right? So definitely the research would say that after 6 months, you start to have the chronic effect. And the chronic effect is not just simply a physical problem. It also is what we would call a neuropathic problem, where you're essentially learning a pathway of pain. And that becomes more difficult to treat. So the sooner you get it taken care of, the better at this point.
Great, thank you.
Okay.
Appreciate that, Diane. Oh, look, he decided to call in. It is Kelvin, our money guy.
And I listen to him all the time.
Of course, yeah.
I've never actually met him.
No? Well, there you go. Cal, what's going on, buddy?
Oh, I meant to wait to ask Dr. Payne my question.
Okay.
But I had to leave. But anyhow, so my palm of my hands, are killing me. It's like almost like arthritis, almost, it feels like.
Okay.
And then the bottom of my feet kills.
How old are you?
56.
Okay. Are you otherwise healthy?
Yeah. When I get up in the morning, I feel like I'm like 100 years old.
How long does it take before you feel less than 100 years old in the morning?
About 5 minutes, not even.
Okay, so that's that. Yeah, so one big distinguishing question when we're thinking of mechanical versus autoimmune issues is when people talk about problems in the morning. So things that are systemic in the body can take a very long time to clear up, 2, 3, 4 hours in the morning. We usually say more than 30 minutes. But as soon as someone says, yeah, after 5 minutes, I'm moving around, it's better, that usually indicates a mechanical type of issue. So it could simply be related to just the things that you're doing, what mechanical means. Now, that doesn't mean that there are things that you can likely do to make it better, but it sounds right off the bat when you say something like that, mechanical, if you're otherwise healthy, not a lot of autoimmune things. Well, I shouldn't say some things can set in at your age, not as common in men. But yeah, I think, are you an active guy, like in terms of the risks can make sense a lot from the sleep positions, because at night you'll do a lot of weird things, a lot of weird movements with the wrist, but knees, are you active otherwise? Like what's going on with that? Any previous injuries?
Not as much anymore, but I will go see Dennis next week at the gym.
Okay.
But I will come in and see you.
Sure. Yeah. We can take a look at it. Again, it doesn't sound overly concerning, but, again, once you leave something for too long, that's the problem. And I mean, if you're not as active as you used to be, that's right. Also a reason why pain starts to set in as well.
Yeah. Okay.
Yeah.
All right.
Okay.
Thank you.
Yeah. Thanks, Calvin. Appreciate that, buddy. The money guy chiming in.
Money guy.
Even the money guys have problems.
Yeah. They got all the money, but they
low money, no problems. It could be wrist problems with the problems. 416
too much.
That's right. 416-870-6400 star 640 on cell C there, Mike and Chris. We will get to you as well. Dr. Payne Show, Global News Radio, 640 Toronto. 11:42. Still got some time to ask your questions. Would love to have you on the show, Mike. In that regard, how are you, pal?
Fine. How are you guys doing?
Good. What's going on with you today?
Okay. About 2012, it started. Right now, I think I have like a rotator cuff, like kind of like what that previous lady was saying.
Mm-hmm.
And I've been going to rehab for 2.5 months.
Mm-hmm.
But I don't know if I need to get an operation to fix it. There's no tear, there's no anything. But do you think it could be calcifying?
Well, have you had an MRI or an ultrasound?
Yes, that's what we found out.
Yeah, and did it say that there was calcification in the tendon?
Yes.
Okay, then there is calcification in the tendon. So yeah, calcification is a problem because it prevents the mobility that the tendon once had. Something that's very good for calcific tendonitis of the shoulder is shockwave therapy.
Yes, that would be the next thing.
And you should give me a call because we work closely with Rob Gordon, who's the medical director of Shockwave. He's directly in our office, so we do Shockwave right. So yeah, give me a call and we can help set you up with somebody. But that might be a good option for you, a good next option if there is calcification in that tendon.
Yeah, I think that could be the last besides an operation. I don't know.
Well, an operation wouldn't work well for the calcification anyway. Okay. So you don't have to worry about that.
Oh, that's good.
Okay.
All right. Thanks, guys.
No problem.
Thanks, Mike. Appreciate that. You can call in as well. You have some time. We have some time. 416-870-6400 star 640 on your cell phone. Chris, thanks for hanging on. How are you?
Good morning, guys. How you doing today?
Good, brother. What's going on? Low back pain, right?
Oh, low. This has been going on maybe, well, not as sharp as it's been recently, but last couple of years, I got a physical job, and just sitting in my car as I speak, I got like burning sensation on the bottom parts of my lower back on both sides.
Okay.
Some days it's worse. Like I'll work and I'll come home and I'll be fine, and in about an hour or two, it's just sharp. I can't move. It takes a bit to get up, but once I'm up, I'm okay. But then somehow it just comes right back. So,
all right.
I've had MRI. I've had an ultrasound. They said I had a bulging disc.
Okay.
One side, and it just seems to be just burning at times where I don't know. It's hard to even.
So what have you done for treatment?
I actually haven't done nothing because I don't have work benefits. So I've tried Voltaren, A535.
Yeah, so you're doing all the wrong things if you've done nothing, unfortunately.
Okay.
So you need to do something, because to just leave it absolutely will not get better on its own and will likely get worse over time. So you need to do something. Now, I think, you should come see me, because even if you don't have work benefits and things like that, that doesn't mean you can't be given an exercise program that you can do on your own at the very least. Something is better than nothing, or even some small amount of treatment, trying to make it affordable. Like anything that's being done right shouldn't be incredibly expensive anyways, because a lot of it is the stuff that you would have to do. So yeah, you need to do something. If you have that type of problem and you're not doing anything, then that's the problem.
Okay, well, I was referred some inflammation pills, which I kind of don't really like to take.
No, and they're likely not doing anything.
Yeah. So I've done stretches. I've done the elastic stretches, and then it just it's fine, and all of a sudden it just comes back. It seems like as soon as I start working and lifting stuff, it just sharp. Yeah. It almost feels like a pinched nerve. I've never had one, but somebody's told me
How old are you?
I'm 43, and I'm healthy.
Yeah, it could be, but. Yeah, I mean, no matter what it is, you got to do something about it. So we can obviously, step one is figure out what exactly is causing it, and step two is, well, let's do something about it. But you got to do it in that order. So yeah, give me a call and come see me.
Okay, I appreciate that, guys, and go Leafs go.
Thanks, Chris. Appreciate that. It's 1-855-55 Dr. Lou, DRLOU, or info@paincarecanada.com. Derek, you're next up. Hey, pal.
Hey, how are you guys today?
Good. What's going on with you today?
Okay, so it's a knee issue. I've had ultrasounds. My doctor says there's nothing wrong with the meniscus, I believe, that's under the knee. What I do find is I've been taking chondroitin, glucosamine chondroitin, and my knee seems to be pretty good and usable. During the dampness, it gets to it during the dampness, but as soon as I go off the chondroitin, my knee gets really pain.
Okay.
And I'm just trying to see if you can kind of link that with maybe an issue with what the chondroitin's doing, helping out somewhere, or...
Well, the glucosamine is good for the reality is glucosamine is not good for treatment of the knee. It's good for prevention of osteoarthritis or slowing it down over time. So a lot of it could just be a placebo effect too, in all honesty, if you're relating it with when you don't take it, there's pain, and when you do, there's no pain. I think it sounds like you don't have a good answer to what your knee pain is due to. Ultrasounds for, like you said that the doctor said it's not a meniscus issue, but there's a lot of other things that could be wrong with it. So I think that you need to figure that out. Well, what is it that is creating your knee pain? And once you have an answer as to what it is, then that's how you determine how to treat it. And how old are you, Derek?
I'm 50 coming up.
Yeah. So any arthritis in that knee?
I really don't know. I used to play hockey when I was younger.
So why are you taking the glucosamine?
Because it seems to be I'm a bell technician, so I'm outside constantly.
Yeah.
I'm constantly walking. If I go off those, like I said, my knees sore all day.
Yeah.
But when I'm on them, I'm manageable.
Okay.
Like I said, the ultrasound, the X-rays, they say that there's nothing there. So for me, I don't know. I don't have a clue unless I get a recheck, I guess.
Yeah. So the biggest thing here is X-rays, ultrasounds are great if there's been a physical exam done. Has someone examined your knee physically properly?
Mm-hmm.
So
which I think my doctor has. So
okay, yeah. So then it might just simply be a functional issue, which is good because that's very treatable. But you shouldn't just be relying on what an X-ray or an ultrasound says. It really comes down to what's a physical exam showing.
Yeah, like when I first initially went to him, that's why I told him it feels like there's pain underneath the kneecap, is what it feels like.
Yeah.
And that's why he did all the ultrasounds and stuff. But
yeah, and that's an important thing. But did he grab your knee, move it around, do different orthopedic testing?
No, he didn't do that on the last test.
Yeah, so that's what needs to be done.
Yeah.
Yep.
Yeah. Okay, I was just wondering if the glucosamine is not something that's going to harm you. It's just going to help you if possible.
Yeah, it may not even help you, but it probably won't harm you either.
What about the turmeric? Because I was told by a lot of elderly people that the turmeric is
same
really
thing.
good.
The natural substances are better for a prevention issue than they are a treatment issue.
Appreciate that, Derek. Continue on. 1-855-55 Dr. Lou, if you so wish. We'll get to your calls. Last few minutes of the show, 416-870. 6,400 star 640 on sale. Right back with more Dr. Payne Show. Global News Radio 640 Toronto. 11:53. A few minutes to go here on the Dr. Payne Show. By the way, you want to carry on after the show is not on. For instance, 1-855-55 Dr. Lou, DRLOU, info at PayneCareCanada.com. Dave, thanks for hanging in, fella. How are you?
I'm not bad. I'm just calling to get some advice and some direction here. I've been dealing with, I had a really bad case of shingles in my forehead and my left eye. Mm-hmm. It's been 2 years. This November 1st will be 2 years. Yeah. And it's just now I'm dealing with the post-herpetic neuralgia, the nerve pain around the eye and the forehead. Yeah, I've been on Lyrica. I've been on gabapentin. I've tried acupuncture. Yeah. Nothing's worked. It's CBD oils. Yep. I've tried. Nothing has worked. And the only thing, I didn't know if there's anything else that you suggest that might help.
The only other thing, I mean, no, not if it was somewhere else in the body, but when you're dealing with the brainstem, like if it was something like around the torso and you could go in and like those procedures like ablation of the nerve. But when you're dealing with the face, you're dealing with the brainstem and you can't really access that. So unfortunately, post-herpetic neuralgia is a very, very tough thing to treat. And it's really more about you consistently doing those things that you are doing consistently. Like it may never fully resolve, but maybe in doing all of those things, there might be some management. But yeah, it's a very, very tough thing to treat.
It's brutal, especially in the evenings when you're tired, and
for sure.
The body slows down a little bit. It's really hard. I just didn't know if there's anything you suggest other than what I've been doing already. So.
No, I think you've already done a lot of the right things. It's more just about continuing to do them. Unfortunately, there's no good answer for that. Unfortunately.
All right. Well, thank you.
No problem.
Thanks, Dave. Appreciate that. Moving on to Greg. Hey, Greg, how are you?
Not too bad. My question is there any scientific evidence that PRP is effective for knee arthritis?
Yes, absolutely. There is. There was a show where we had Dr. Rob Gordon and Dr. Manoj Bhargava, who are two orthopedic surgeons, specifically knee stuff, and they went through a lot of the literature around PRP for specifically knee osteoarthritis. So with mild to moderate knee osteoarthritis, there's about a 75% success rate with PRP injections, and that's the best scientific evidence for PRP is with the knee osteoarthritis.
How about the synovial fluid injections?
Not as good from a research perspective.
And PRP, how long does it last?
The research would suggest that the effects can start as early as 3 months all the way up until 12 months. And then in terms of, there's not very many studies that have followed patients much longer than that. So that's hard to say. But clinically, what we've seen is some people can get up to 2 years with some elimination of the inflammation and relief from their pain.
Does it stimulate any stem cells at all?
No. It's just simply designed to break down the inflammation that's in the knee. It does nothing in terms of changing or regenerating or anything like that. It's just simply a lot of the pain around mild to moderate osteoarthritis is as a result of the inflammation that happens within the joints. The platelets will naturally break down that inflammation, and that is the goal of the PRP treatment.
And the cost of that is?
That depends on where you go get it. So, but I've seen it range, all the way from $500 or $600 to over, $1,100 or $1,200. It just depends on who's doing it, what protocol they're using, and that. Our team, I believe, the fee is around $750, and we do it based on the research, which was one injection of. Can't remember exactly off the top of my head the exact measurement, but we're more on the the more minimalistic side of it. We're not overdoing it.
I see.
Yeah.
Thanks very much.
No problem.
Thanks, Greg. Appreciate the call. Once the say 1 to 2 years usefulness, I'll say, of the PRP, can it be repeated?
Yeah, absolutely.
You do it again and again.
Yeah.
Okay.
Yeah. It's and if it is working, you should probably do it every year. And that's why I say the cost depends, because some places out there are making people come back every 3 months. Or again, we're basing it on the research, the review of the literature that we have, and we're going to do one injection once a year. for mild to moderate knee osteoarthritis. I have a lot of people that come in, they have severe knee osteoarthritis. They want to do the PRP because they hear our commercials or they've heard the show, and it's like not going to help you.
Yeah.
Don't waste your money. So we don't do it to everybody, that's for sure.
As far as the procedure is concerned, is it a time-consuming to do and painful or no?
No.
Really?
I mean, there's an injection that's going into the knee, but again, these are knee surgeons doing it. It's it's not like it doesn't feel like anything, but it's not. You're not going to not be able to walk type of thing.
It's not a root canal.
No, it's not a root canal
like that.
No.
We're pretty much done for another broadcast day here in the Dr. Payne Show. You'll want to follow up, get some advice, consultation. At least go visit and take the first steps. 1-855-55-DR-LOU, DRLOU, and always info@paincarecanada.com. Till next time, it'll be next weekend right here, Dr. Payne Show, Global News Radio, 640 Toronto.